Affirming Project Manager for Denver Prevention Training Center. Thank you all for being here today. We're about to get day one started for our summit, and I would like to introduce our two MCs for today, Ryan O'Connell and London Smith. Get some snaps.
All right, good morning, everyone. It's my pleasure to welcome you all to the 2022 HIV Care and Prevention Summit. See all of me, the intersections of medical mistrust and distrust and its impact on transgender health. My name is Ryan O'Connell. I accept he, him, his pronouns, and I'm one of your MCs for today's summit. We're excited about the overwhelming response to this summit. We have over 650 registrants representing a range of professions, expertise, and community organizations from all over the country. A representation perhaps that shows it's truly going to take a village to tackle lifetimes of marginalization and erasure and move into a more positive and affirming future for trans and non-binary communities. I'm out of Denver, so before I begin, I'd like to acknowledge that I'm on the traditional territories and ancestral homelands of the Cheyenne, Ute, and Arapaho nations. Gender is a colonial system, and there will be no trans liberation without Indigenous sovereignty. I'd also like to acknowledge the Centers for Disease Control and Prevention and the Health Resources and Services Administration for their support of this conference. Putting conferences together takes time and work, so I'd like to thank the amazing Summit Planning Committee. Committee member names should be listed on the slide on the screen. Members of the committee represented the following organizations: Primary Care Development Corporation, My Brother's Keeper Incorporated, San Francisco Community Health Center, Chicago, the Denver Prevention Training Center, the San Francisco Department of Public Health, the California Prevention Training Center, the Pacific AIDS Education and Training Center, the Mountain West AIDS Education and Training Center, the CHIPS program at UCLA, the Office of the Assistant Secretary for Health Region 9, and the Prevention Through Active Community Engagement program. Before we begin, it's also important to acknowledge our privilege to enjoy this conference while trans communities in Ukraine are quite literally fighting for their lives, having to leave their support, safety nets, and access to life-saving, gender-affirming, and HIV care to cross borders and seek asylum into systems that have not been created to support them. When we were planning this conference, I couldn't help but think about the increasing availability of trainings on gender-affirming care and trans visibility more broadly. Maybe it's a consequence of the work I do, but I feel like every time I open my email, my inbox offers another opportunity to sign up for webinars and trainings on working with trans folks. There have also been several period pieces popping up on TV showcasing the 1980s and impact of the AIDS crisis on trans communities, particularly on Black and Brown trans communities. Despite the importance for exposing audience to this history and the many firsts in representation of trans communities of color, certainly an overdue moment that's not to be diminished. And trans representation is never so simple. So when there are so few mainstream representations, we also need to be critical. The work of gender studies professors Eva Hayward and Laura Stam have made me wonder if we might need to be asking if the positioning of these shows as a period piece should make us wonder about the effects of making the AIDS crisis historical. The mainstream media has only a few representation of trans women of color living with HIV. It's dangerous to put that representation in the past. It can push current lived experience outside of our field of vision, as well as the need for treatment and activism in our present historical moment. Reading for representation plays a pivotal role in facilitating self-understanding, but reading for scarcity or absence of representation can show inadequacies of what's there. We can find ourselves as self-represented at the same time, and even if existing archive is far from representative. Trans people and communities have become more visible in the last several years, and even though these communities have always existed, it feels new to the masses, even if it's not. Mainstream representation has consequences, even when positive. More visibility can result in more violence and political backlash, and this intersection is not often addressed. Even as 2021 was one of the deadliest on record for trans people, we're still facing the dual threat of an unprecedented number of anti-trans bills in state legislatures and resurgence of stigmatizing and demeaning rhetoric from cultural, social, and political figures domestically and internationally. With COVID restrictions and gender-affirming care and surgeries, there have become a present moment's emphasis on the linkage between transness, healthcare, and the concept of being non-essential. With COVID, there's been frequent parallels to AIDS and HIV, but analogy often collapses difference. And we forget that with COVID, the media response was to prop up a shared sense of a unified people that will preserve and overcome illness, recovering as a whole national body. Eric Stanley reminds us that while COVID had nurses and doctors flying to New York City, during the AIDS crisis, they were trying to escape. Trans communities, and particularly those living with HIV, are facing frequent, severe, and widespread threats to safety, health, and well-being, making the idea of medical mistrust and distrust both historical and deeply present. While there is a possibility of transformation by hearing and learning about the violence and impact of historical traumas, I don't want to overemphasize tragedy at the expense of trans joy and resilience. This month, on March 31st, we celebrate Transgender Day of Visibility. Founded in 2009, it was a response to the frustration that the only known transgender day was Transgender Day of Remembrance, which mourns the murders of transgender people, but did not acknowledge and celebrate living members of the community. The other side of tragedy is that we've been able to see new versions of visibility. Rather than white trans women out of history, as mainstream accounts of LGBT and HIV activism tend to do, this moment asserts that trans women of color were and are putting their bodies on the line. There's a sense of power felt by people who are most affected by an issue, who are capable of transforming the world and don't need some other person who has more access to resources or in a different relationship to power to swoop in and solve a situation. My own ability to exist as a trans person in public today is not thanks to medical models that have overemphasized physical form and wrong body narratives, but thanks to the self-knowledge, determination, and everyday resistance in the face of criminalization of Black trans leaders, and particularly Black trans women who have paved the way, women who we should be honoring and celebrating as we move into Women's History Month. Professor Julie Boulay reminds us that we often say they survived COVID, they survived HIV, they survived a trans childhood. But what happens when we're convinced something is not really happening to us? This misapprehension, the belief we can turn away and survive untouched, precludes us from seeing ourselves as part of a collective, a belongingness forged out of enduring and surviving. The classic us-them dualism minimizes violence against or death of others, the only them rhetoric of early HIV public health. Those who turn away think they have something to gain or nothing to lose. But what it would mean to talk about these topics as though it were happening to all of us. This is the question that invites us to turn toward, to see ourselves as subjects of events, as people who have also lost something, even when, or especially when, we cannot yet articulate or imagine that loss. New laws being pushed forward in Texas show that it very much is happening to all of us. Parents, guardians, medical workers, and pharmacists who help trans kids obtain medically approved treatment for transition are officially criminalized. But even outside of direct medical care and social support for trans people, trans communities have given all of us the possibility of refusing certainties and closures for ourselves, allowing us to ooze out of the template of what we think we're supposed to say about ourselves in the world. Right before I started medical transition, my counselor asked me how my life might be different if I can transition. I think at the time I had some answer about living an authentic life and being seen as who I really am. But as time has gone by, I agree with Alec Bademenon that authenticity is an orientation, not a destination. People want there to be linear and clear before and after, then and now, who I was and who I was meant to be. It's more difficult to accept that we're always becoming. We've become obsessed with finding answers instead of just living the open question of who we are and who we could be, and remembering this is always changing. It's about moving out of the box that limits us and into infinite possibilities. Trans and non-binary communities can expand this possibility for everyone. The best thing you can do is show up, walk alongside, and learn how this resilience has manifested for lifetimes and learn from it. Trans bodies, not trans lives, and very rarely trans voices, have provided the basis for learning about gender and what it means to be trans, with an overemphasis on physical form. The challenge then of the intersection between HIV and transness is to resist producing a representation that is definitive. By focusing on visibility, should we ask who we're making ourselves visible for? Are we better off asking about and speaking about what structures foreclose community, identity, the body, and agency? Visibility and representation can be deeply affirming. So if nothing else, perhaps we can challenge the latent assumptions embedded in the visible, the representational, or semantic. We believe that this summit is set apart from what you're usually given. Our committee strongly believed it was crucial to assure the many voices of trans and non-binary communities, voices that are most prone to being drowned out by the noise of the world, were instead amplified and could represent a wide range of the trans experience. The planning committee worked hard to secure dynamic speakers, panelists, and presenters from across the United States, many of whom are leading voices in gender-affirming care, HIV advocacy, and thought. I have permission to tell you all of the speakers you will hear from over the course of the next 2 days identify as part of trans and non-binary communities in some way, some of whom are also living with HIV. There are so many questions, so much that require attention. Going into today, sit with an uncertainty and conceptual openness that might incite new and different questions. Our speakers and panelists may show you that the investment in gender alone obscures how we can think about lived experience and address mistrust, and may shine a different light on the relationship between HIV, race, transness, and representation. As you're listening to yourself, or as you're listening, ask yourself, how does each speaker's individual experience challenge what I think I know about the trans experience and HIV? Turn to lived experience so that instead of offering quick solutions, you might ask better questions and become freshly curious about what you do not yet know. This does not resolve erasure or offer the final word, just an invitation to deepen and challenge the questions we can offer. We thank you all so much for attending today. Your attendance demonstrates one piece of your commitment to hearing and learning from trans communities on how to address and work towards alleviating lifetimes of medical distress for transgender and non-binary communities, and particularly for those living with HIV. Now, I'd like to hand it over to my co-MC, London Smith, to introduce you to our plenary speaker.
Thank you so much, Ryan, for that wonderful welcome and start to the summit. Greetings to all the attendees. My name is London Smith de Richelieu, and it is my honor to introduce our opening plenary speaker, someone who I hold in high esteem and have the privilege to call my sister, Dr. Tatiana Moten. Dr. Moten, PhD, she, her, is a senior capacity building specialist at San Francisco Community Health Center / Chicago. Dr. Moten is passionate about health equity, is a fierce advocate for HIV and AIDS resources, and works endlessly to create a world where transgender people are able to not only live, but thrive. Dr. Moten is the CEO and principal consultant for Envision Consulting, one of the first Black trans-led consulting firms in the country. She has an extensive experience working in human resources, championing strategic initiatives geared towards diversity and inclusion. Tatiana is a veteran of the U.S. Armed Forces, serving honorably as an intelligence officer in the U.S. Army. She was reared in the city of Chicago and attended college in Milwaukee, Wisconsin. She recently obtained her Doctor of Philosophy in Management Science. She is a staunch advocate for trans community and has worked with American Civil Liberties Union as a spokesperson for trans litigation and Lambda Legal. Working with the U.S. Center for Disease Control's Science Application Team as a consultant to develop the first intervention geared towards the transgender targeted population. Tatiana is a faculty member of the Transgender Strategy Center and has worked with organizations and companies such as AIDS United, NMAC, Gilead, Merck, Elton John AIDS Foundation, and the Black AIDS Institute. It brings me a tremendous honor to introduce my dear friend and esteemed sister, Dr. Tatiana Moten.
Thank you so much, London. Good morning and good afternoon, everyone, depending on where you are. It is such an honor to be here with you all today for something that is close and dear to my heart, particularly advocating for those in the trans community. Being a Black trans woman myself, I am oftentimes asked, why do you continue to do this work? You have passing privilege, you've done everything else. Why do you continue to stand in the gap for those who necessarily have not found their voice? Because I don't like to say people who don't have a voice, for those who have not found their voice. And I live my life by a mantra that says, I will continue to fight because I know one day I will encounter someone who is not strong enough to fight the battles that I may have already won. So that is why I continue to do what it is that I do. I am really, really excited to be here with you all and to walk through this presentation or plenary of See Me As I Am and Not How You Want Me to Be. I chose that title specifically because trans persons, when they are accessing healthcare and other services, there's a tendency by providers to immediately start diagnosing and pathologizing and all of these things, when essentially what we are asking for is to be seen. And in the ways that we want to be seen is for you to allow us to be the experts of our own experiences. So see me as I am and not how you want me to be. An intersectional look at providing transgender health. And I use the word intersectionality because in as much as I am a trans person, I oftentimes show up as a Black woman. That is who I am. And so when treating me or servicing me or providing me these services, take all of these considerations and when providing or designing your treatment plans. When you encounter trans people, the one thing that you have to oftentimes pay attention to, particularly if you're operating from an intersectional approach, is that we oftentimes show up as we are. And when I say show up as I am, all of the way that I may have gotten to your door or to your desk has been shaped by all of the experiences that led to that. Next slide. As London said, I'm a senior capacity building specialist with San Francisco Community Health Center, but out of our Chicago remote office, we have been funded to provide technical assistance within the Midwest, but we encourage you to reach out to those within your regions for technical assistance following this presentation. My area of expertise is clinical HIV testing, is our track, and my prevention for persons living with HIV. Next slide. And so anytime I do a presentation or give a talk, I like to set the stage. And so transgender is an umbrella term used to describe people whose gender identity and or gender expression differ based on the sex they were assigned at birth. The transgender community is not a monolith. Transgender people have diverse sexual orientations, gender expressions, and gender identities. And transgender identities do not depend on physical appearance or medical procedure. Discrimination, stigma, and violence, along with other social, political, and economic factors, significantly affect the health, physical, mental, and behavioral health of transgender adults. Research demonstrates that compared with the general population, transgender people suffer from more chronic health conditions and experience higher rates of health problems related to HIV and AIDS, substance use, mental illness, and sexual and physical violence. The public health and economic crisis spurred by the COVID-19 pandemic have only exacerbated existing disparities and barriers to care for transgender people, especially transgender people of color. Next slide. Today, I would hope that you would walk away with some of these learning objectives. I'm going to provide you a historical perspective on medical mistrust, because like I said, with the title intersection, we're going to walk through a historical perspective from the African American community, myself being a trans woman, but also a person of color. We will differentiate between sexual orientation, biological sex, gender identity, and gender expressions. Many of these terms and concepts will not be new to you all, but this is just a refresher, specifically because of the importance of providing culturally competent and culturally responsive care for those trans persons. We will review a short list of key terms that are important to this population. We will define intersectionality and describe why it is important to understanding the health disparities for transgender people. We will identify social determinants of health and health disparities for this population. We will identify strategies for decreasing barriers to care for this population and solutions for decreasing health disparities. We will also increase awareness of resources to improve care to this population. So let's get right into it. The title of this seminar is called Medical Mistrust. I'm going to provide a historical perspective that is applicable to the African American community. But the parallels I want you to see in this is that we only have so far to look and gather an understanding of how medical mistrust is built. Next slide. And so this is Dr. Ephraim McDowell. Dr. Ephraim McDowell is an American surgeon who is considered a founder of operative gynecology. He was the first to successfully remove an ovarian tumor in 1809, demonstrating the feasibility of elective abdominal surgery. But what did he do? Dr. Ephraim McDowell perfected his dangerous and radical surgery on non-consenting enslaved women. Next slide. This is Dr. Crawford Long. Dr. Crawford Long is known as the discoverer of anesthesia. Since that time, he has been recognized by medical bodies all over the world and has been memorialized by monuments, statues, paintings, and even a US postage stamp. But what did he do? Dr. Crawford Long conducted the majority of his early experiments on non-consenting enslaved men and women. Next slide. This is Dr. J. Marion Sims. Dr. J. Marion Sims was an American physician and a pioneer in the field of surgery, known as the father of modern gynecology. His most significant work was the development of a surgical technique for the repair of vaginal fistula, a severe complication of obstructed childbirth. What did he do? Dr. J. Marion Sims performed his surgery on non-consenting enslaved women addicting them to narcotics to sedate and immobilize them post-operatively. He also performed the surgery repeatedly on the same women. This is John Brown was an escaped enslaved who fled to England and dictated his memoirs, which were published under the title Slave Life in Georgia, a narrative of the life, sufferings, and escape of John Brown, a fugitive slave now in England. In his memoirs, he recalls experiences with Dr. Thomas Hamilton, who used heat therapy as an experimental method to treat Brown after years of abuse as a slave. The method entailed forcing Brown to sit on a box while a fire burned beneath him to test the impact of extreme heat on the body. One of the most probable note is the Tuskegee study. In 1932, the Public Health Service, working with the Tuskegee Institute, began a study to record the natural history of syphilis, called the Tuskegee Study of Untreated Syphilis in the Negro Male. The study was conducted without the benefit of patients' informed consent. The men were never given adequate treatment for their disease. Even when penicillin became the standard of care in treatment for syphilis in 1947, researchers did not offer it to the subjects. The study lasted until 1972. The last US Public Health Service syphilis study at Tuskegee participant died on January 16, 2004. And so when we look at the historical trauma and medical mistrust, the institution of medicine in the United States was built with the lives of Black and African Americans. The United States has a history of creating mistrust through systematic discrimination and abuses of people of color and other marginalized groups. For example, forced sterilizations at the US-Mexico borders and in women's prisons. The US Public Health Service infected Guatemalan prisoners with STIs to test penicillin. And so when we ask ourselves, particularly as we're the closeness of COVID-19 and those who are resistant to vaccines and all of these other things, we only have to look at a historical perspective of how medical mistrust is built. And in relation to the trans community, when you're asking yourselves, particularly for trans people of color, why is it that they are not coming to receive these services? Or why, can I not get my patient or client to open up to me? As I talked about in the beginning, taking an intersectional approach to these things is understanding that most of the traumas that we have experienced and the ways that we show up are coupled by the experiences that we have been through. Next slide. And so one of the ways that medical mistrust is oftentimes built, and some of the ways that I have observed, is the first thing that you do with your patient or client is affirming them with language. And so on the slide here, you have some former language about gender and some current language about gender. When using these terms, such as trans women, referring to them male to female or M to F, that is an improper way of doing that. Because as a trans person, I have never embodied anything other than who I am. And bringing the two into congruence has been a process for me. And so when you mislabel a trans person and use things such as what are your preferred pronouns or feminizing, when talking about hormones, female or male hormones, these are some of the ways that mistrust is built. Because if I am not affirmed from my initial contact with a provider, then the trust is automatically shut off. Next slide. And so when thinking about using some of these terms, reframing or changing the focus, and I oftentimes say to providers and clinicians, allow your clients and sometimes patients to be the experts of their own experiences. Allow them to dictate to you what it is that they would like to be referred and how it is that they would like to be referred. And there's nothing wrong with simply asking. When in doubt, ask. Because what you will oftentimes find is that we are in position to teach you about who we are, but don't allow that to become a lengthy process or something where every encounter that you're having with your patient or client is that they are educating you. Take the time to make these personal investments. Next slide. And so when we talk about some of these things and the healthcare disparities that have been experienced by trans people, this was from the National Transgender Survey, last completed in 2015. And I would like to note that they are doing recruitment for the next survey that is in process. Disparities in health and healthcare among transgender people have been documented in prior research. The survey explored several areas related to healthcare, including respondents' overall physical and mental health and their experiences accessing healthcare services, both related to gender transition and routine healthcare. Results related to health and healthcare were presented in 6 sections. Those were routine and transition-related healthcare and coverage, overall health and psychological distress, conversion therapy and other pressures to detransition, suicidal thoughts and behaviors, substance use, HIV testing and care. Why it's important that we teach medical students on gender diverse health. 33% of those who saw a healthcare provider in the past year reported having at least one negative experience relating to being transgender, with higher rates for people of color and people with disabilities. 6% were verbally harassed in a medical setting, such as a hospital office or clinic. 5% a healthcare provider used harsh or abusive language when treating them. 24% taught their medical providers about transgender care. And 23% postponed or avoided medical treatment when sick or injured. I don't know about you, but for me, particularly being in HIV-related care, one of the most important things for us is along the continuum is retention into care. If trans people are having these experiences when they are accessing care, what does this say or how does this impact their retention into care? Next slide, please. And so these are some first voice experiences by healthcare disparities experienced by trans people. One person said, I've been refused emergency room treatment even when delivered to the hospital by ambulance with numerous broken bones and wounds. And so myself having the experience of going to the ER for a chest cold or not being, asthma or some of those things. And it turns into me seeing one provider. And now there's 20 other medical students or providers that are coming into the room. And now I'm being asked to disrobe and all of these things that have nothing to do with the chest cold or breathing issues that I'm experiencing. And so another one says here, I was forced to have a pelvic exam by a doctor when I went in for a sore throat. The doctor invited others to look at me while he examined me and talked to me about my genitals. I've been living with excruciating pain in my ovaries because I can't find a doctor who will examine my reproductive organs. This is from a transgender man. Like I said, I don't know about you, but these things are very alarming to me. But they are not new and they're not unique. Next slide. And so, like I said, see me as I am and not how you want me to be. It is very, very important for you to understand that when trans people are showing up into your offices, into your clinics, or even accessing services via telehealth, there are special considerations that should be made. And even if you're not willing or wanting to do these things, it is adversely affecting those people who are most needing this care. If we are saying that trans people are a high priority for HIV prevention and care, if we are not affirming those very same people and who they are, we're doing just as much harm to them as when they first showed up at our doors. Next slide. And so I put this slide here as an illustration to kind of, like I said, most of these concepts are not new to folks, but I want to put it here for illustration that my gender identity is much different and part and partial from my sexual attraction. And that has nothing to do with my sex. And none of those three have anything to do with gender expression. And so these concepts are not interchangeable, and they are part and partial from each other. And so to have an understanding of people that you're working with means taking the time to understand what these things essentially mean. Next slide. And so as we see here, these are some of the examples when we are talking about these concepts and topics. Gender identity, the things that fall under there would be cisgender, transgender, genderqueer. Under gender expression, these would fall under gender nonconforming, gender conforming folks, because I myself, I transitioned to be a part of the binary. And I want to caution folks, in as much as you are creating spaces of inclusion, be cautious and be wary that you are not also creating spaces of inclusion. If you are providing services for trans people, be very specific that these are for transgender people. When you start to couple things like trans, gender nonconforming, and non-binary, yes, we're respectful and inclusive of our non-binary siblings, but if the priority is trans people, be specific and say that. Tailor your services specifically for trans people, because the way you may view the gender binary or the gender as a galaxy, for most trans people, it is very binary and very linear. Next slide, please. And so as a clinical skills tip, when in doubt, ask. Terms change constantly and carry different meanings for different people. Don't be afraid to ask your clients or patients about their identity. Thank you for sharing me that you identify as transgender. Please tell me more about what that means so that I can provide you with the best care possible. Next slide. And so the history and context of LGBT health. We have the AIDS crisis of 1980s to 1990s. As London was discussing earlier in my introduction, I was a part of a team of trans women who came up, or were a part of, the curriculum development team of TWIST, which is the first intervention developed specifically for transgender women. When we think about in context of the AIDS and HIV crisis, the height of the HIV and AIDS crisis was between 1980s and 1990s. And so LGBT identities pathologized by medicine, mental health, and homosexuality was removed from DSM in 1973. Gender identity was removed and replaced by gender dysphoria in the DSM in 2013. And so conversion therapy is widely used without consent. Earlier variations included electric shock and chemical castration. Conversion therapies are still in use today, despite ample evidence that it causes harm and does not work. As you know, LGBT communities are diverse, and LGBT people are of every race, ethnicity, color, nationality, and etc. Your patients bring all of their identities to the encounter with you. They may have heard their friends, parents or grandparents tell stories of times when mistreatment was more widespread. The role of distrust in the clinical encounter, a historical context important in understanding patient distrust. As we talked about earlier, some of those examples, the Tuskegee syphilis experiment, James Marion Sims experiment on gynecological surgeries, most performed without anesthesia, the trials for oral contraceptive and pills in Puerto Rico, forced sterilizations, US Public Health Service infected Guatemalan prisoners with STIs to test penicillin. Earlier change occurred in 2013 when gender identity disorder was dropped from the Diagnostic and Statistical Manual of Mental Disorders, the 5th edition, US Psychiatry's Bible for diagnosing mental illness. A new condition called gender dysphoria was added to diagnose and treat those transgender individuals who who felt distressed at the mismatch between their identities and their bodies. The new diagnosis recognized that a mismatch between one's birth gender and identity was not necessarily pathological. Notes pediatric endocrinologist Norman Speck, a founder of the Gender Clinic at Boston Children's Hospital. It shifted the emphasis in treatment from fixing the disorder to resolving distress over the mismatch. And so as we move into intersectionality, now that we have set the foundational basis, let's take a look at where they meet, and that's intersectionality. Next slide, please. And so intersectionality is a term coined by, next slide, I'm sorry, coined in 1989 by American civil rights activist Kimberly Williams Crenshaw to describe what she saw as failures of the system in responding to domestic violence against poor Black women. Intersectionality is a framework for conceptualizing a person, group of people, or a social problem as affected by several discriminations and disadvantages. It considers people's overlapping identities and experiences in order to understand the complexity of prejudices they face. Intersectionality, like I said, is a framework for conceptualizing these things. And so in as much as you may not understand all of the issues that are affecting the trans community, you can certainly understand some of the disparities that have been faced because they are not unique to our community. They are experienced by Black women, by Black men, men who have sex with men, and others who are impacted by these prejudices. Next slide. Intersectionality promotes an understanding of human beings as shaped by the interaction of different social locations. And these interactions occur within the context of connected systems and structures of power. And so when we're talking about the medical mistrust and the medical industrial complex, a lot of these structures of power have been kind of skewed, or the disparities that have been experienced by this community have been because of these structures of powers. And through such processes, interdependent forms of privilege and oppression are shaped by colonialism, imperialism, racism, homophobia, ableism, and patriarchy are created. Even in these ways that programs are created for trans people, but trans peoples are not the leaders of these programs. This is a form of patriarchy. What we're doing is saying that you are good enough to receive the services. You may even be good enough to participate in these, but where does the worth in leading the charge for these things? Next slide. And so as I said earlier, I show up as I am, but understand that this has been shaped by what I have been through. I encourage you all, if you ever have the opportunity or occasion, to go back and look at YouTube and other channels for Dr. Kimberly Crenshaw's talk on intersectionality and how that is even being weaponized outside of its true intent. But what we are saying in this context, again, I show up as I am, but I need you to understand that this has been shaped by what I have been through. So when building trust or encouraging these trusts amongst your patients and clients, understand that in as much as you are showing up and wanting to have a deeper understanding of these things, I also have all of the experiences that have led up into this point. So exercise a little grace. Next slide. As a clinical skills tip, how can you put a fearful client at ease? Acknowledge their fears and reassure them. For example, ask, what have your experiences been like before in mental health care? Or say, I understand that you or people you know have experienced harm, but know that the best practice now is, and whatever that best practice or promising practices are, and state to your clients or patient, I will follow those best practices. Next slide. And so when we talk about disparities in social determinants of health for the trans community, while robust laws that protect transgender people from discrimination based on gender identity are essential to providing greater legal safeguards, such tools must be paired with enforcement mechanisms and in-practice policies that are affirming, inclusive, and culturally competent. Now, remember what I said, it's not enough no longer to just be culturally confident. You also have to be culturally responsive. And being culturally responsive means tailoring those services to the population that is in your particular community. What trans and access to services looks like for me in Chicago will not be the reality of what that looks like for my trans siblings who are living in Alabama or Mississippi or even in Atlanta. And so when you're considering these programs and creating services specifically for trans people, ensure that you're tailoring them to meet the needs of the community. Because like I said, just coming with this cookie cutter approach to services, it's not going to work. Next slide. Adopting both non-discrimination laws and inclusive policies will be critical for improving health outcomes and the daily lives of the estimated 1.4 million adults identifying as transgender in the United States. And so some of the social determinants of health, one of particular concern would be economic stability. Examples, rejection of transgender youth by families contribute to higher rates of homelessness for transgender youth. Lack of legal protections for transgender people in housing and employment contributes to housing instability and financial instability for this population. Health and healthcare. Some of the examples of this are healthcare providers lacking training, contributes to patients dropping out of care, receiving substandard care, and concealing key information in care settings. The goal here is to get a full understanding of your patient so that you can effectively treat them. But you can't do that if there's this distrust that is built there. Social and community context. Social isolation of a stigmatized group forces socialization into bars, contributing to higher rates of alcoholism, drug abuse, and smoking. Bullying of youth perceived to be LGBTQ is widespread and common, contributing to poor mental health outcomes for youth and adults. Next slide. And so to talk about the experiences of trans people, we also have to take the considerations of minority stress. High levels of chronic stress faced by members of stigmatized minority groups. This is what we're talking about when we're referring to minority stress. Minority stress describes chronically high levels of stress faced by members of stigmatized minority groups. It may be caused by a number of factors, including poor social support and low socioeconomic status. But the most well understood causes of minority stress responses, for example, high blood pressure, anxiety, that accrue over time, eventually leading to poor mental and physical health. Minority stress theory summarizes these scientific studies to explain how difficult social situations lead to chronic stress and poor health among minority individuals. It is an important concept for psychologists and public health officials who seek to understand and reduce minority health disparities. Next slide. And so what are some solutions? We know what the problems are. How do we get past that? Seek further educational experiences that support your growth. These can be done through increasing self-awarenesses of one's own assumptions and attitudes. Check yourself. Let this be daily. Let this happen daily. Because as I talked about earlier, language evolves and it changes. Some of the concepts that I've just talked to you about now may have become outdated even as we're speaking and viewing this plenary now. So always strive, become that lifelong learner. What true intersectionality and cultural competence speaks to, committing to lifelong learning, and learn clinically relevant information. These can be done through peer-to-peer learning, reaching out to your AETCs, and requesting technical assistance service and CEBA services. They're free. These are opportunities to educate and expound the experiences and the knowledge that you have surrounding this community. Advocate on behalf of this population in healthcare environments and in public policy. I'm oftentimes asked, how can I show up as a better advocate? And I tell people all the time, speak for me even when I'm not there. You have a duty to do these things. If you are committing, like I said, to cultural competence and that lifelong learner, speak up for those populations that are not there at the table. Make your research inclusive by collecting demographics for these populations. What is your sexual orientation? What is your assigned gender at birth? What is your gender identity? But I caution you, Ask these terms only if it's applicable to what it is that you're providing. Ask questions, avoid assumptions in order to get accurate information. Never make the assumption that you know everything. Even myself, being a woman of trans experience, I should say, I don't know everything there is to know about trans people, but I, again, make that commitment to learn and to grow. Next slide. And so some strategies for culturally effective care. Build trust by creating an inclusive healthcare environment, inclusive non-discrimination policies and intake forms. And I'll say this, it is not just enough to have these policies, but where you are posting and making these policies visible, that is the key. Visual cues and waiting rooms, rainbow lapel pins, and even trans flag pins. These are simple identification methods that a person can have in securing that psychological safety. Advocate for record the patient's name and use and pronouns, and advocate for systems-wide use. Some of these things can be done in your EMRs that your patients never have to see some of these things. These can be front-facing tweaks that can be done to your EMRs and even your HRIS systems. And that stands for Human Resources Information Systems for those people who will be working at your organization. Advocate for training for all staff and providers. Advocate for safe, respectful workplaces. We spend much of our lives in our workplaces. If we don't feel psychologically safe, then we are not being our whole self. Build trust by acknowledging potential distrust of medical systems and professionals. Ask, have you had any poor experiences with healthcare providers in the past? And the key here is to listen. Next slide. Some other strategies for culturally effective care would be assure confidentiality and ask questions about sexual orientation and gender identity in all situations where it could be important to the patient care. The key here is where it could be important. Don't just ask these questions if you're just out of pure plain curiosity that has nothing to do with the course of care that we're providing. And when we're talking about these things, like I said, ensure confidentiality. As we have seen during the COVID-19 pandemic, there was a great shift towards telehealth and providing these services in a virtual setting. The key here is setting that stage for your patient or client. It may take a simple turning off the virtual background and showing the person who's in the room and ensuring them that you are the only person there. These are simple ways that you can ensure psychological safety. Ask permission before you record LGBT identity into the EHR. Is it really important, or is this, going to be impacting of this person's care? Making those considerations. Use universal language. How would you like to be addressed? Do you currently have a partner, as opposed to saying, do you have a husband or a wife? Changing and reframing your approaches. Do not ask questions out of curiosity. Contextualize sensitive questions to establish clinical relevance. I cannot tell you enough that we are keen to pick up on these things when they have no applicability to what's going on. And I could pretty much flesh out, hey, this person is just being, curious, and this has nothing to do with my care. Giving the example of going to the ER for a chest colon, now this turns into, can you disrobe for a pelvic exam? What does that have to do with why I'm here? So like I said, do not ask questions out of curiosity. Contextualize sensitive questions to establish clinical relevance. Next slide. And so some of the national resources, I want to bring your attention to the CDC's Toolkit for Providing HIV Prevention Services to Transgender Women of Color. This was a toolkit that was developed out of the SPINS initiative. And this is just one resource that I really is my go-to. It has a wealth of information for working with trans individuals, providing care, and all of those things. But there's also the Fenway Institute, National LGBT Health Education Center, the Gay and Lesbian Medical Association, and the Center of Excellence for Transgender Health out of San Francisco, and shameless plug. San Francisco Community Health Center has a rich history of providing technical assistance, and we pride ourselves on providing services specifically for the trans community. And our Trans Thrive team is always available and ready to answer the call for providing best practices and even some promising practices within the context of programs and services that we are doing that are innovative and leading the charge for providing quality and affirming services for trans people. Next slide, please. So I want to thank you all so much for listening to me during this. So thank you so much. Enjoy the rest of the summit. It has been a joy and an honor with you all. Thank you.
Okay. Hello. Hello. Thank you so much. Thank you so much, Dr. Moten. We're going to take a brief break.